Okay, starting with the general cancer readings from Iggy, starting with pages 893 to 898. Hematologic problems result from the impaired production, the impaired function, or the abnormal destruction of any type of blood cell. Problems of the hematologic system can affect many tissues and organs by interfering with the human need for oxygenation and tissue perfusion. The type and severity of the disorder determine the impact it has on the health of patients. This chapter discusses mild hematologic disorders and those that are potentially life-threatening, such as sickle cell disease and leukemia. Red blood cell disorders. Red blood cells, or RBCs, also known as erythrocytes, are the major cell in the blood. Tissue oxygenation depends on keeping the circulating number of RBCs within the normal range of the person's age and gender. It also depends on the ability of RBCs to perform their normal functions. The RBC disorders include problems in production, function, and destruction. Problems may result in poor function of RBCs, decreased numbers of RBCs, or anemia, or excess of RBCs, polycythemia. Anemia. Anemia is a reduction in either the number of RBCs, the amount of hemoglobin, or the hematocrit, percentage of packed red blood cells per deciliter of blood. It is a clinical sign, not a specific disease, because it occurs with many health problems. Anemia can result from dietary problems, genetic disorders, bone marrow disease, or excessive bleeding. GI bleeding is the most common reason for anemia in adults. There are many types and causes of anemia. Some are caused by a deficiency in one or more of the components needed to make fully functional RBCs. Such anemias can be caused by deficiencies of iron, vitamin B12, folic acid, or intrinsic factor. Other causes include a decreased rate of RBC production and increased RBC destruction. Table 42.1 lists common causes of many anemias. Despite the many causes of anemia, the effects of anemia on the patient, chart 42.1, and the nursing care needed are similar for all types of anemia. Table 42.1, common causes of anemia. Sickle cell disease. Common causes would be autosomal recessive inheritance of two defective gene alleles for hemoglobin synthesis. Then there's glucose 6-phosphate dehydrogenase, or G6PD deficiency anemia. And that would be X-linked recessive deficiency of the enzyme G6PD. Then there's autoimmune hemolytic anemia. This would be abnormal immune function in which a person's immune and reactive cells fail to recognize his or her own red blood cells as self cells. Then there's iron deficiency anemia. That would be inadequate iron intake caused by iron deficient diet, chronic alcoholism, malabsorption syndrome, and partial gastrectomy. Also, rapid metabolic anabolic activity caused by pregnancy, adolescence, and infection, all related to iron deficiency anemia. Then there's vitamin B12 deficiency anemia. That would be dietary deficiency, also failure to absorb vitamin B12 from intestinal tract as a result of partial gastrectomy, or pernicious anemia. And there's folic acid deficiency anemia. That'd be a dietary deficiency, malabsorption syndromes, drugs like oral contraceptives, anticonvulsants, and methotrexate. Then there's aplastic anemia, which would be exposure to myelotoxic agents like radiation, benzene, chloramphenicol, alkylating agents, antimetabolites, antimetabolites, there we go, sulfonamides, and insecticides. Also, viral infection, unproven, would be Epstein-Barr virus, hepatitis B, and cytomegalovirus. So chart 42.1, key features of anemia. Integumentary manifestations would be pallor, especially of the ears, the nail beds, the palmar creases, the conjunctivae, and around the mouth. Cool to touch, intolerance of cold temperatures, nails become brittle and may lose the normal convex shape. Over time, nails become concave and fingers assume club-like appearance. Cardiovascular manifestations of anemia would be tachycardia at basal activity levels, increasing with activity and during and immediately after meals, murmurs and gallops heard on auscultation when anemia is severe, and orthostatic hypotension. Respiratory manifestations would be dyspnea on exertion and decreased oxygen sat levels. On the neurological manifestations would be increased somnolence and fatigue and headache. Anemias resulting from increased destruction of red blood cells. Sickle cell disease. Pathophysiology. Sickle cell disease is a genetic disorder that results in chronic anemia, pain, disability, organ damage, increased risk of infection, and early death. There is a difference between sickle cell disease state and sickle cell trait. In addition, there is a great variation among patients in how severe the disease is and when complications start. The main problem in this disorder is the formation of abnormal hemoglobin chains. In healthy adults, the normal hemoglobin molecule has 2 alpha chains and 2 beta chains of amino acids. This normal adult hemoglobin is called hemoglobin A, or HbA. Normal adult hemoglobin usually is 98% to 99% HbA, with a small percentage of fetal form of hemoglobin called HbF. In sickle cell disease, at least 40% and often much more of the total hemoglobin contains an abnormality of the beta chains, known as hemoglobin S, or HbS. HbS is sensitive to changes in the oxygen content of the RBC. When RBCs having large amounts of HbS are exposed to decreased oxygen states, the abnormal beta chains contract and pile together within the cell, distorting the shape of the RBC. These cells assume a sickle shape, becoming rigid and clumped together, causing the RBCs to become sticky and fragile. These clumps form masses of sickled RBCs that block blood flow. This blood vessel obstruction leads to further tissue hypoxia, reduced oxygen supply, and more sickle-shaped cells, which then leads to more blood vessel obstruction and ischemia in the affected tissues. Repeated episodes of ischemia lead to progressive organ damage from anoxia and infarction. Conditions that cause sickling include hypoxia, dehydration, infections, venous stasis, pregnancy, alcohol consumption, high altitudes, low environmental or body temperatures, acidosis, strenuous exercise, and anesthesia. Figure 42.1, red blood cell actions under conditions of low tissue. And yeah, okay, so usually sickle cells go back to normal shape when the low oxygen condition is removed and proper tissue perfusion resumes. Although the cells then appear normal, at least some of the hemoglobin remains twisted, decreasing cell flexibility. The cell membranes become damaged over time and cells are permanently sickled. The membranes of cells with HbS are more fragile and more easily broken. The average lifespan of an RBC containing 40% or more of HbS is about 12 to 15 days, much less than the 120-day lifespan of normal RBCs. This reduced RBC lifespan causes hemolytic or blood cell destroying anemia in patients with sickle cell disease. The patient with sickle cell disease has periodic episodes of extensive cellular sickling called crisis. The crisis may have a sudden onset and can occur as often as weekly or as seldom as once a year. Many patients are in good health much of the time, with crises occurring only in response to conditions that cause local or systemic hypoxemia or deficiency oxygen in the blood. Repeated blockages of larger blood cells have long-term damaging effects on tissues and organs. Most effects occur as a result of tissue hypoxia, anoxia, ischemia, and cell death. Tissues and organs begin to have small infarcted areas. Eventually, so many healthy cells are destroyed that organ failure results. Organs most often affected in this way are the spleen, liver, heart, kidney, brain, bones, and retina. Etiology and genetic risk. Sickle cell disease is a genetic disorder with an autosomal recessive pattern of inheritance. See Chapter 6. The formation of the beta chains of hemoglobin depends on a pair of gene alleles, alternate forms of a gene. A mutation in these alleles leads to the formation of HBs instead of HBA. In sickle cell disease, the patient has two HBs gene alleles, one inherited from each parent, usually resulting in 80% to 100% of the total hemoglobin containing HBs. Patients with sickle cell disease have severe manifestations of the disease, even when triggering conditions are mild. If a patient with sickle cell disease has children, each child will inherit one of the two abnormal gene alleles and at least have sickle cell trait. If sickle cell trait, one normal gene allele and one abnormal gene allele are inherited, so only half of the hemoglobin chains produced will be abnormal. The patient is a carrier of the HBs gene allele. The patient can pass the trait on to his or her children, but the patient has only mild manifestations of the disease under severe precipitating conditions because less than 40% of the hemoglobin is abnormal. Figure 42.2 shows the genes doing their thing there. Okay, incidence, prevalence. Sickle cell trait and different forms of sickle cell disease occur in people of all races and ethnicities, but less often among white people. In the United States, about 70,000 people have sickle cell disease, most commonly African Americans. Sickle cell disease occurs in 1 in 400 African Americans and 1 in 12 to 1 in 15, 8% African Americans are carriers of one sickle cell gene allele and have sickle cell trait. Patient-centered collaborative care. Assessment. History. An adult with sickle cell disease usually has a long-standing diagnosis of the disorder. An adult with sickle cell trait usually has no symptoms or abnormal laboratory findings other than the presence of hemoglobin S. This person may be unaware that he or she has a problem until an acute illness is present or when anesthesia is administered. Ask him or her about previous crises, what led to the crisis, severity, and usual treatments. Explore recent contact with ill people and activities to determine what caused the current crisis. Ask the patient about symptoms of infection as the cause of crisis, such as sore throat, cough, GI changes, or pain and burning upon urination. Review all activities and events during the past 24 hours, including food and fluid intake, exposure to temperature extremes, drugs taken, exercise, trauma, stress, recent airplane travel, and ingestion of alcohol or other recreational drugs. Ask about changes in sleep and rest patterns, ability to climb stairs, and any activity that includes shortness of breath. Determine his or her perceived energy level using a scale ranging from 0 to 10, 0 not tired with plenty of energy, 10 total exhaustion, to assess the degree of fatigue. This activity review provides important information about fatigue, activity tolerance, and participation in ADLs. Physical assessment / clinical manifestations. Pain is the most common symptom of sickle cell crisis. Jaundice may also be present with Rbc destruction and release of bilirubin. Other manifestations vary with the site of tissue damage. Cardiovascular changes, including the risk of high-output heart failure, occur because of the anemia. Assess the patient for shortness of breath and general fatigue or weakness. Other problems may include murmurs and the presence of an S3 heart sound. Assess his or her cardiac and vascular status by comparing peripheral pulses, temperature, and capillary refill in all extremities. Extremities distal to blood vessel occlusion are cool to the touch with slow capillary refill and may have reduced or absent pulses. The heart rate may be rapid and the blood pressure low to average. with a decreased pulse pressure because breakage of RBCs leads to anemia. Anemia results in a less viscous or thinner blood that moves more rapidly through the heart and blood vessels under low pressures than does normal viscous blood. Priapism is a prolonged penile erection. This complication can occur in men who have sickle cell disease as a result of vascular engorgement in erectile tissue. The condition is very painful and can last for hours. During the priapism episode, the patient usually cannot urinate. Skin changes include pallor or cyanosis because of poor oxygenation from decreased perfusion and anemia. Examine the lips, tongue, and nail beds, conjunctivae, palms, and soles of feet at least every 8 hours for subtle color changes. With cyanosis, the lips and tongue are gray, and the palms, soles, conjunctivae, and nail beds have a bluish tinge. Another skin manifestation of sickle cell disease is jaundice. Bilirubin present inside RBCs is released when fragile cells are damaged, leading to jaundice. Assess for jaundice in patients with darker skin by inspecting the roof of the mouth for a yellow appearance. Yellow-tinged sclera may be misleading because of normal deposits of fat that appears yellowish in contrast to the dark skin around the eye. Examine the sclera closely to the cornea to assess jaundice more accurately. The palms and soles of dark-skinned patients may appear yellow if callous and could be mistaken for jaundice. Jaundice often causes intense itching. Despite the anemia, patients with sickle cell disease usually are not iron deficient. In fact, with increased RBC production and destruction, iron release from the cells may increase the pigmentation of the skin. As many as 75% of adults with sickle cell disease have open sores or ulcers on the lower legs that are caused by poor skin tissue perfusion. The outer sides and inner aspect of the ankle or the shin are common ulcer sites. Inspect the legs and feet for open lesions or darkened areas that may indicate necrotic tissue. These lesions often become necrotic or infected, requiring debridement and antibiotic therapy. Skin grafting may be needed when ulcers fail to heal. Abdominal changes include major organ damage to the spleen and liver. These organs are usually the first to be damaged from many episodes of hypoxia and ischemia. In crisis, abdominal pain is diffuse and steady, involving the back and legs. Bowel sounds should be present with normal activity. Palpate the liver and spleen for enlargement. The liver or spleen may feel firm and enlarged with a nodular or lumpy texture in later stages of the disease. Check for guarding or rebound tenderness to palpation. A rapidly enlarging liver or spleen that occurs with increasing jaundice may indicate blood trapping in those organs. Renal and urinary changes are common as a result of poor perfusion and decreased tissue oxygenation. Chronic kidney disease occurs as a result of anoxic damage to the kidney nephrons. With early damage, the kidneys are less effective at filtration and reabsorption. The urine contains protein, and the patient may be unable to concentrate urine. Eventually, the kidneys fail, resulting in little or no urine output. The buildup of toxic waste product in the blood leads to death. Musculoskeletal changes occur because arms and legs are common sites of blood vessel occlusion in sickle cell disease. Joints also may be damaged from hypoxic episodes and have a necrotic degeneration. Inspect the arms and legs for symmetry and record any areas of swelling or color difference. Ask patients to move all joints, record the range of motion and any pain with movement. Central nervous system changes may occur in sickle cell disease. During crisis, patients may have a low-grade fever. If the CNS has infarcts or repeated episodes of hypoxia, patients may have seizures or manifestations of a stroke. Assess hand grasps on both sides. Assess the patient's gait and coordination. Psychosocial assessment. Psychosocial assessment is important because behavioral changes are early manifestations of cerebral hypoxia from poor tissue perfusion. Observe the patient and document behavior. Ask family members whether the current behavior and mental status are usual for the patient. Sickle cell disease is a painful, life-limiting disorder that can be passed on to one's children. Assess the patient's psychosocial needs in terms of new factors, establish support systems, use of coping patterns, and disease progression. Ask the patient about how he or she views the disease and what changes in lifestyle have been made as limitations increased. Laboratory assessment. The diagnosis of sickle cell disease is based on the large percentage of hemoglobin S, HbS, seen on electrophoresis. A person who has sickle cell trait usually has less than 40% HbS, and the patient with sickle cell disease may have 80% to 100% HbS. This percentage does not change during crisis. Another indicator of sickle cell disease is the number of RBCs with permanent sickling. This value is less than 1% disease, among people who do not have sickle cell disease, is 5% to 50% among people with sickle cell trait, and may exceed 90% among patients with sickle cell disease. Other laboratory tests can indicate complications of the disease, especially during crisis. The hematocrit of patients with sickle cell disease is low, between 20% and 30%, because the lifespan of the RBC is so much shorter than normal and because many cells are destroyed. This value decreases even more during crisis or when the bone marrow fails to produce cells during stress, a plastic crisis. The reticulocyte count is high, indicating anemia of long duration. It is high because the bone marrow is releasing immature red blood cells, or reticulocytes, to make up for the low hematocrit and resulting tissue hypoxia. Often the total bilirubin levels are high in patients with sickle cell disease because bilirubin is released from damaged and dead red blood cells. The total white blood cell, or WBC count, is usually high in patients with sickle cell disease. This elevation is related to chronic inflammation caused by tissue hypoxia and ischemia. Imaging assessment. Bone changes occur as a result of chronically stimulated marrow and low bone oxygen levels. The skull may show changes on X-ray as a result of bone marrow or bone surface cell destruction and new growth, giving the skull a crew cut appearance on X-ray. X-rays of joints may show necrosis and destruction. Other diagnostic assessment. Electrocardiographic or ECG changes document cardiac infarcts and tissue damage. Specific ECG changes are related to the area of the heart that has been damaged. CT and PET and MRI may show soft tissue and organ changes from poor oxygenation and chronic inflammation. Common nursing diagnoses and collaborative problems. Nursing diagnoses and collaborative problems that may apply to the patient with sickle cell disease include acute pain related to poor tissue oxygenation, chronic pain related to joint destruction, potential for sepsis, potential for multi-organ dysfunction, and death. Interventions: acute pain, chronic pain. The most common problem of sickle cell disease is pain. The pain with sickle cell crisis is the result of tissue injury caused by poor oxygenation from obstructed blood flow. At times, patients have mild pain episodes that can be managed at home. However, pain is often severe enough to require hospitalization and large doses of opioid analgesics. Acute pain episodes have a sudden onset, usually involving the chest, back, abdomen, and extremities. Complications of sickle cell disease, such as bone necrosis, can cause severe chronic pain, requiring low doses of opioid analgesics, or large doses, of opioid analgesics. Ask the patient whether the pain is typical of past pain episodes. If not, other pain causes or disease complications must be explored. Use of a pain rating scale can help proper pain management. Ask the patient to rate the pain on a scale ranging 0 to 10 and evaluate the effectiveness of interventions based on the ratings. Concerns about substance abuse can lead to inadequate pain treatment in these patients. Opioid addiction is rare, occurring in only 2 to 5% of patients with sickle cell disease. The treatment of pain is based on past pain history, previous drug use, disease complications, and current pain assessment. Healthcare providers need to be aware of their own attitudes when caring for this population. If substance abuse is suspected, the treatment of addiction is incorporated into the patient's overall treatment plan. Management of substance abuse in sickle cell disease poses many challenges because the patient usually cannot be expected to be totally opioid-free. Addicted patients with acute pain crisis may need opioids for short periods. Drug therapy for patients in acute sickle cell crisis often starts with at least 48 hours of IV analgesics. Chart 42.2 lists Best practices for nursing care of the patient in sickle cell crisis. Morphine and hydromorphone dilaudid are given IV on a routine schedule or by infusion pump using patient-controlled analgesia or PCA. See Chapter 5. Once relief is obtained, the IV dose can be tapered and the drug given orally. Avoid as-needed PRN schedules because they do not provide adequate relief. Avoid IM injections because absorption is impaired by poor perfusion and sclerosed skin. Moderate pain may be treated with oral doses of opioid or NSAIDs. See Chapter 5 for more information on pain management. Chart 42.2. Best practices for patient safety and quality care. Care of the patient in sickle cell crisis. Administer oxygen. Administer pain medication as prescribed. Hydrate the patient with normal saline IV and with beverages of choice without caffeine orally. Remove any constrictive clothing. Encourage the patient to keep extremities extended to promote venous return. Do not raise the knee gauge of the bed. Elevate the head of the bed no more than 30 degrees. Keep room temperature at or above 72 Fahrenheit. Avoid taking blood pressure with external cuff. Check circulation in extremities every hour. Pulse ox of fingers and toes, capillary refill, peripheral pulses, and toe temperature. Back to the text. Hydroxyurea or droxia has been successfully used to reduce the number of sickling and pain episodes. Hydroxyurea works by stimulating fetal hemoglobin or HbF production. HbF is present during fetal development, but its production is turned off before birth. Increasing the level of HbF reduces sickling of red blood cells in patients with sickle cell disease. However, this drug is associated with an increased incidence of leukemia. Long-term complications should be discussed with the patient before this therapy is started. Hydroxyurea also suppresses bone marrow function, and regular follow-up to monitor complete blood counts, CBCs, for drug toxicity is important. Hydroxyurea also causes birth defects. Thus, sexually active women of childbearing age should use at least 2 methods of birth control while taking this drug. Hydration by the oral or IV route helps reduce the duration of pain episodes. Urge the patient to drink water or juices. Hypotonic fluids such as dextrose 5% in water or dextrose 5% in 0.45% sodium chloride are infused at 250 milliliters an hour for 4 hours. Hypotonic fluids are used because the patient's blood volume is usually hypertonic as a result of dehydration. Using the hypotonic fluids can help bring the patient's blood osmolarity back down to the normal range of 270 to 300 MOSMs. The IV rate is then reduced to 125 milliliters an hour if more hydration is needed. Complementary therapies and other measures such as keeping the room warm, using distraction and relaxation techniques, positioning with support for painful areas, aromatherapy, therapeutic touch, and warm soaks or compresses all help reduce pain perception. Do not assume that these methods alone will provide adequate pain relief. Analgesics are needed to manage sickle cell pain. Potential for sepsis. The patient with sickle cell disease is at greater risk for bacterial infection because of decreased spleen function resulting from anoxic damage to the spleen. Over time, the spleen may become completely non-functional. Interventions aim at preventing infection, controlling infection, and starting treatment early for specific infections. The patient who develops a fever should have diagnostic testing for sepsis, including a CBC with differential blood cultures, reticulocyte count, urine culture, and a chest x-ray. Usually these patients are started on prophylactic antibiotics. Prevention and early detection strategies are used to protect the patient in sickle cell crisis from infection. Frequent, thorough hand washing is of the utmost importance. Any person with an upper respiratory tract infection who must enter the patient's room wears a mask. Use strict aseptic technique for all invasive procedures. Coordinate with all members of the healthcare team to ensure adherence to these strategies. Continually assess the patient for infection and monitor the daily CBC with differential WC count. Inspect the mouth every 8 hours for lesions indicating fungal or viral infection. Listen to the lungs every 8 hours for crackles, wheezes, or reduced breath sounds. Each time the patient voids, inspect the urine for odor and cloudiness and ask about urgency, burning, or pain during urination. Take vital signs at least every 4 hours to assess for fever or supervise this action when performed by others. Drug therapy is a major defense against the infections that develop in the patient with sickle cell disease. Prophylactic therapy with twice-daily oral penicillin reduces the number of pneumonia and other streptococcal infections. Urge the patient to receive yearly influenza vaccinations and to receive the pneumonia vaccine. Drug therapy for an actual infection can control infection and prevent sepsis. Drugs used depend on the sensitivity of the specific organism causing the infection as well as on the extent of the infection. Potential for multiple organ dysfunction. Continued blood vessel occlusion by clumping of sickled cells increases the risk for multiple organ dysfunction. Management of sickle cell disease focuses on prevention of blood vessel occlusion and promotion of oxygenation. The patient in sickle cell crisis is admitted to the acute care hospital. Assess for adequate perfusion to all body areas. Remove restrictive clothing and instruct the patient to avoid flexing the knees and hips. Hydration is needed because dehydration increases cell sickling and must be avoided. Assist him or her in maintaining adequate hydration. The patient in acute crisis needs an oral or IV intake of at least 200 milliliters an hour. Oxygen is given during crisis because lack of oxygen is the main cause of sickling. Ensure that oxygen therapy is nebulized to prevent dehydration. Monitor saturation using pulse oximetry. Patients with low oxygen saturation should have an arterial blood gas (ABG) drawn and a chest X-ray. Transfusion with RBCs can be helpful to increase HbA levels and dilute HbS levels. During transfusion, monitor the patient for complications of the procedure discussed on page 920 and 921. Transfusions are prescribed cautiously to prevent iron overload from repeated transfusions. Iron overload damages the heart, liver, and endocrine organs. Monitor the patient's serum ferritin, serum iron, and total iron binding capacity, TIBC. Deferoxamine, mesylate, or desferal, or desferoxamine, or deferocyrox, or Xjade, may be prescribed to treat transfusion-induced iron overload. In some treatment centers, hematopoietic stem cell transplantation, or HSCT, is performed to correct abnormal hemoglobin permanently. Because HSCT is expensive and may result in chronic and life-threatening complications, its risks and benefits need to be considered for each patient. Decision-making challenge. Coordination of care. A 21-year-old African-American man who has a history of sickle cell disease is brought to the emergency department at midnight. He and his family are from out of town and flew in earlier in the day. The patient tells you he has joint and back pain. He is very fearful because the pain is getting progressively worse. He rates his pain as a 9 on a 0 to 10 scale. He is pale and his vital signs are normal except for slight tachycardia. He is still nauseated and from the motion sickness induced by the plane trip. He says that he has been able to drink only about 2 cups of liquid today. What questions related to pain would you ask this patient? What drugs would you expect this patient to receive and by which route? What diagnostic tests would you expect to be requested for this patient? What nursing assessments would be most important for you to make at this time? What factor or factors could have triggered this crisis episode? Okay. Community-based care. Sickle cell disease becomes worse over time. Rarely is there a true remission, although the number of crisis episodes may be reduced. Care focuses on teaching the patient and family how to prevent crisis and complications. Chart 42.3. The patient with sickle cell disease may receive care in different settings, including acute care, subacute care, extended or assistive care, and home care. Chart 42.3. Patient and Family Education Guide, Prevention of Sickle Cell Crisis. Drink at least 3 to 4 liters of liquid every day. Avoid alcoholic beverages. Avoid smoking cigarettes or using tobacco in any form. Contact your healthcare provider at the first sign of illness or infection. Be sure to get a flu shot every year. Ask your healthcare provider about taking the pneumonia vaccine. Avoid temperature extremes of hot or cold. Be sure to wear socks and gloves when going outside on cold days. Avoid planes with unpressurized passenger cabins. Avoid travel to high altitudes, e.g. cities like Denver and Santa Fe. Ensure that any healthcare professional who takes care of you knows you have sickle cell disease, especially the anesthesia provider and radiologist. Consider genetic counseling and screening. Avoid strenuous physical activities. Engage in mild, low-impact exercise at least 3 times a week when you are not in crisis. Back to text. Teach the patient to avoid specific activities that lead to hypoxia and hypoxemia. Stress the recognition of the early symptoms of crisis so that interventions can be started early to prevent pain, complications, and permanent tissue damage. He or she is often given opioid analgesics for self-management of sickle cell crisis at home. Teach the patient and family about the correct use of these drugs. In addition, counsel patients about the heredity aspects of sickle cell disease and provide information about prenatal diagnosis, birth control methods, and pregnancy options. Women's health considerations. Pregnancy in women with sickle cell disease may be life-threatening. Patients who have damage to vital organs are advised against becoming pregnant. Usually barrier methods of contraception, cervical cap, diaphragm, or condoms with or without spermicides are recommended for women with sickle cell disease. The use of oral contraceptives, or OCs, is controversial because OCs may increase clot formation, especially among smokers, predisposing them to crisis. The risks versus benefits of OCs must be examined for each patient. And that was sickle cell disease. Interesting. Okay, now I'm going to read pages 901 and 902. Polycythemia. In polycythemia, the number of red blood cells, or RBCs, in the blood is greater than normal. The blood of a patient with polycythemia is hyperviscous, thicker than normal blood. The problem may be temporary, occurring as a result of other conditions, or chronic. One type of Polycythemia Vera, or PV, is fatal if left untreated. Polycythemia Vera, Pathophysiology. Polycythemia Vera, PV, is a disease with a sustained increase in blood hemoglobin levels to 18 grams per deciliter, an RBC count of 6 million per millimeter to the third, or a hematocrit of 55% or greater. PV is a cancer of the RBCs with 3 major hallmarks: massive production of RBCs, excessive leukocyte production, and excessive production of platelets. Extreme hypercellularity, or cell excess, of the peripheral blood occurs in people with PV. The patient's facial skin and mucous membranes have a dark, flushed, or plethoric appearance. These areas appear purplish or cyanotic because the blood in these tissues is poorly oxygenated. Most patients have intense itching caused by dilated blood vessels and poor tissue oxygenation. Blood viscosity is increased, resulting in hypertension. Superficial veins are visibly distended. The thick blood moves more slowly through all tissues and places increased demands on the heart, resulting in hypertension. In some highly vascular areas, blood flow may become so slow that stasis occurs. Vascular stasis causes thrombosis, a clot formation within the smaller vessels, occluding blood vessels. The blood vessel occlusion leads to tissue hypoxia, anoxia, and later to infarction and necrosis. Tissues most at risk for this problem are the heart, spleen, and kidneys, although infarction and damage can occur in any organ or tissue. Because the actual number of cells in the blood is greatly increased and the cells are not completely normal, cell lifespans are shorter. The shorter lifespans and increased cell production cause a rapid turnover of circulating blood cells. This rapid turnover increases the amount of cell debris released when the cells die in the blood, adding to the general sludging of the blood. This debris includes uric acid and potassium, which cause the symptoms of gout and hyperkalemia, elevated serum potassium level. Other manifestations of PV are related to abnormal RBCs. Even though the number of RBCs is greatly increased, their oxygen carrying capacity is impaired, and the patients have poor oxygenation with severe hypoxia. Patients with PV also have bleeding problems because of platelet impairment. Patient-centered collaborative care. Polycythemia Vera is a malignant disease that progresses in severity over time. If left untreated, people with PV live longer than 2 years after diagnosis. With treatment by repeated phlebotomies 2 to 5 times per week, the patient may live 10 to 15 years or longer. Phlebotomy is the blood drawing with removal of the patient's RBCs to decrease the number of RBCs and reduce blood viscosity. Increasing hydration and promoting venous return help prevent clot formation. Therapy aims to prevent clot formation and includes the use of anticoagulants. Chart 42.5 lists health tips for patients with PV. As the disease progresses, drug therapy is used to control it, although aggressive IV chemotherapy is no longer recommended because of its increased risk for inducing leukemia. Aspirin therapy may be used to decrease clot formation. However, the benefits must be weighed against the increased risk for GI bleeding associated with this therapy. Hydroxyurea, an oral chemotherapy drug, may be prescribed for severe manifestations of the disease. Chart 42.5, Patient and Family Education Guide, Polycythemia Vera. Drink at least 3 liters of liquid each day. Avoid tight or constrictive clothing, especially garters or girdles. Wear gloves when outdoors in temperatures lower than 50 degrees Fahrenheit. Keep all healthcare-related appointments. Contact your physician at the first sign of infection. Take anticoagulants as prescribed. Wear support hose or stockings while you are awake and up. Elevate your feet whenever you are seated. Exercise slowly and only on the advice of your physician. Stop activity at the first sign of chest pain. Use an electric shaver. Use a soft bristle toothbrush to brush your teeth. Do not floss your teeth. Next we have myelodysplastic. Myelodysplastic syndromes. Pathophysiology. Myelodysplastic syndromes, or MDSs, are a group of disorders caused by the formation of abnormal cells in the bone marrow. These abnormal cells are usually destroyed shortly after they are released into the blood. As a result, patients with MDS have a decrease in all blood cell lines. Anemia is the most common problem, occurring in 90% of patients with MDS, although neutropenia, low white blood cell count, and thrombocytopenia, low platelet count, are also often present. MDS can occur at any age. However, the disease is most common in people age 60 years or older. Although not officially a type of cancer, MDS has cancer-like features and is considered to be a precancerous state. Like cancer, MDS arises from a single population of abnormal cells. About 30% of all patients with MDS do eventually develop acute leukemia. There are many subtypes of MDS, and problems can range from unresponsive anemia to cytopenia, low blood cell counts, with increased numbers of blast cells, or immature white blood cells. White blood cells. The exact cause of MDS is not clear. Risk factors include normal physiologic changes associated with aging, chemical exposures, pesticides, benzene, tobacco smoke, and exposure to radiation or chemotherapy drugs. Diagnosis is made by examination of the chromosomes and the genes within the chromosomes, cytogenetic testing of the bone marrow cells. Peripheral blood smears are used to assess the level of cell maturation and the proportion of abnormal cells. Patient-centered collaborative care. Treatment of MDS focuses on symptom management and supportive care. Supportive care of the patient with MDS includes blood transfusions for anemia and platelet transfusion for severe thrombocytopenia. Erythropoietin may be given in addition to transfusions. The use of frequent transfusions may result in iron overload and organ damage. Okay, and that was those. Oh, wait, there's more. Okay, chelation therapy may be needed to reduce the iron overload before damage to the liver and heart occurs. Chelation is the chemical binding of iron and its removal from the body. This therapy is indicated for patients who receive more than 20 units of red blood cell transfusions, or for those whose serum ferritin levels are greater than 2,500 micrograms per liter. Drugs used for management of iron overload include Exjade, Desferal, and Desferoxamine. White blood cell disorders. As discussed in Chapter 19, white blood cells, or WBCs, or leukocytes, provide protection from infection and cancer development. This protection depends on maintaining normal numbers and ratios of the different mature circulating WBCs. When any one type of WBC is present in either abnormally high or abnormally low amounts, immune function is altered to some degree, as are oxygen transport and blood clotting, placing patients at risk for many complications. This section covers the changes and nursing care for patients with disorders involving overgrowth of specific types of WBCs. See Chapter 21 for more problems and care needs for patients with immune deficiency. All right, Leukemia Pathophysiology. Leukemia is a type of cancer with uncontrolled production of immature WBCs, usually blast cells, in the bone marrow. As a result, the bone marrow becomes overcrowded with immature, non-functional cells, and production of normal blood cells is greatly decreased. Leukemia may be acute, with a sudden onset and short duration, or chronic with a slow onset and symptoms that persist for years. Leukemias are classified by cell type. Leukemic cells coming from the lymphoid pathways, see Figure 19.3 in Chapter 19, are typed as lymphocytic or lymphoblastic. Leukemias in which the abnormal cells come from the myeloid pathways are typed as myelocytic or myelogenous. Several subtypes exist for each of these diseases, which are classified according to the degree of maturity of the abnormal cell and the specific cell type involved. Biphenotypic leukemia is acute leukemia that shows both lymphocytic and myelocytic features. With leukemia, cancer occurs in the stem cells or early precursor leukocyte cells, causing excessive growth of a specific type of immature leukocyte. These cells are abnormal, and their excessive production in the bone marrow stops normal bone marrow production of RBCs, platelets, and mature leukocytes. Anemia, thrombocytopenia, and leukopenia result. Often the number of immature, abnormal WBCs in the blood is greatly elevated, and these cells cannot provide infection protection. Leukemic cells can also be found in the spleen, liver, lymph nodes, and central nervous system. Without treatment, the patient will die of infection or hemorrhage. For patients with acute leukemia, these changes occur rapidly and without intervention, progress to death. Chronic leukemia may be present for years before changes appear. Etiology and genetic risk. The exact cause of leukemia is unknown, although many genetic and environmental factors are involved in its development. The basic problem involves damage to genes controlling cell growth. This damage then changes cells from a normal to a malignant cancer state. Analysis of the bone marrow of a patient with acute leukemia shows abnormal chromosomes about 50% of the time. Possible risk factors for the development of leukemia include ionizing radiation, exposure to chemicals and drugs, bone marrow hypoplasia or reduced production of blood cells, genetic factors, immunologic factors, environmental factors, and the interaction of these factors. Ionizing radiation exposures such as radiation therapy for cancer treatment or heavy radiation exposure, e.g. the atomic bomb at Hiroshima or the nuclear accident at Chernobyl, increase the risk of leukemia development, particularly acute myelogenous leukemia or AML. Chemicals and drugs have been linked to leukemia development because of their ability to damage DNA. Previous treatment for cancer that included melphalan, doxorubicin, etoposide, and cyclophosphamide poses risks for leukemia development about 5 to 8 years after treatment. Table 41.3 in Chapter 41 lists chemicals and drugs that damage the hematologic system. Bone marrow hypoplasia can increase leukemia risk by reducing or changing the rate of bone marrow cell production. Disorders that have marrow hypoplasia and may lead to leukemia development include Fanconi's anemia and myelodysplastic syndromes. Genetic factors influence leukemia development. There is an increased incidence of the disease among patients with hereditary conditions such as Down syndrome, Bloom syndrome, Klinefelter syndrome, and Fanconi's anemia. Identical siblings of patients with leukemia have a higher incidence of leukemia than does the general population. Immunologic factors, especially immune deficiencies, may promote the development of leukemia. Leukemia related to immune deficiency may be a result of immune surveillance failure, or the same mechanisms that cause the immune deficiency may also trigger cancer in the WBCs. Interaction of many host and environmental factors may result in leukemia because each person tolerates the interaction of these factors differently. It is difficult to determine the origin of any specific leukemia. Incidence/prevalence. Leukemia accounts for 2% of all new cases of cancer and 4% of all deaths from cancer. The incidence depends on many factors, including the type of WBC, affected age, gender, race, and geographic locale. In the United States, about 44,000 new cases of leukemia occur each year. Leukemia is classified into any one of 4 types based on cell type affected and how fast the disease progresses. Acute myelogenous leukemia, AML, is the most common form of adult onset leukemia. Acute Promyelocytic leukemia, APL, is a subtype of AML that makes up about 10% of adult onset AML. Acute lymphocytic leukemia, or ALL, makes up about 10% of adult onset leukemias, but is most common in children. In adults with ALL, the Philadelphia chromosome, usually the hallmark of chronic myelogenous leukemia, is a common chromosome abnormality. Chronic myelogenous leukemia, or CML, makes up about 20% of adult onset leukemias, occurring more often in people older than 50 years. A major feature of CML is the presence of the Philadelphia chromosome abnormality in the leukemic cells. CML has 3 phases. The chronic phase is often a slowly progressing indolent course during which the patient may have mild symptoms and responds to standard treatments. The bone marrow usually shows less than 10% blasts. At this time, the accelerated phase features spleen enlargement and progression manifestations such as intermittent fevers, night sweats, and unexplained weight loss. The patient usually does not respond to standard treatment, and the bone marrow may contain 10% to 30% blast cells and promyelocytes. This phase typically lasts 6 to 12 months. The blast phase indicates a transformation to a very aggressive acute leukemia. The bone marrow contains more than 30% blasts. The promyelocytes and blast cells commonly spread to other tissues and organs. And then there's the chronic lymphocytic leukemia. CLL is a rare type of leukemia that occurs most often in people older than 50 years and appears to have a hereditary component. Average survival time ranges from less than 19 months for patients diagnosed with advanced disease to more than 10 years for patients diagnosed with early stage disease. Okay, and that's leukemia and some other stuff. 900 to 902 or 901, 902, something like that.